I always have to check what we're called. The Mental Health Network of the Faculty of Homeless and Inclusion Health. It is nice to see familiar and unfamiliar faces. We're being recorded, and by attending, we consent to being recorded. So if you don't, let yourself be known or leave, I guess. My name's Jenny Drife. I'm the consultant in the START team, which is the CMHT for people sleeping rough in South London. When I'm chairing, but as always, Sophie has done all the hard work of arranging the meeting. So thank you very much, Sophie, and Jonathan for putting the invites out. So we're packed as usual. Today we've got 2 speakers and a hot topic, and then a word from Alex at the end. If anyone has anything else they want to discuss, please save it for any other business. People who have been here before know it's a nice informal meeting, so please chat by putting things in the chat box or by raising your hand. And if you haven't been here before or you think it's necessary, please introduce yourself in the chat box. So I'm going to hand over to John Pritchard. Jen, are you here? Yes, I can see you.
Yes,
who
I am.
is the
Morning.
Associate Director for Housing and Community at Southern Health. And I will leave you to introduce yourself. Over to you.
Super, thank you very much. Let me just get my slides up. Bear with me a moment. There we go. Hopefully you can all see that.
Yep.
Excellent. All right. No, I can't see you, so by all means, just holler if something goes wrong or you've got a question to ask. But there's plenty of time for questions at the end if that's easier. So good morning, everybody. Hello, and thank you for inviting me to today's network meeting. My name's John Pritchard, and as Jenny said, I'm Associate Director of Housing and Community Inclusion at Southern Health NHS Foundation Trust. So I've been invited to come and speak to you today about my fairly unique role within the NHS. Oh. Sorry, has that moved on?
Yep.
Yeah, brilliant. Okay. Good. So as I say, so it's a fairly unique role. I'm one of only 2 associate director level colleagues within the NHS focused on housing. And there are 3 main streams to my role. One is looking at the discharge destinations for our service users. So where are we discharging people to? How are we discharging them? Along with the links to housing teams in our local districts and boroughs. Secondly, as a trust, we're doing lots of work around our approach and strategy towards key worker accommodation, especially in the light of an increasing internationally recruited workforce. And thirdly, changing how we work with our partners in the community to keep people safe and well at home, enabling people to live their best lives in their own home as much as possible. So this work enables my colleagues to move away from a purely medical model of health and well-being to a social model which embeds health, driving more sustainable discharges. Alongside me, we have some brave and bold system colleagues who absolutely understand the importance of using home as a lens to well-being, which really supports my work. Our ICP strategy reflects this work targeting health inequalities. So this morning I'm going to run you through a couple of examples of how we're working with local authority partners and other statutory and VCSE organisations to ensure that people are either able to stay in their own homes for longer or can move through the system more swiftly. So firstly, let's look at one example of how we've grown beyond the initial response to the Everyone In campaign implemented at the start of COVID. Strengthening links with local authorities has enabled us to continue to safeguard people who are homeless or who are at risk of homelessness. We've created new partnerships between local authorities and Southern Health, embedding mental health clinicians into local authority housing teams. And currently, we've got 5 posts live covering 6 local authority areas. So at their most basic level, these roles are preventing hospital admissions, avoiding evictions, keeping people safe and well in the community, employing a multi-agency safeguarding response, and ensuring that accommodation offers from local authorities are appropriate to the individual's needs. The impact of the joint working runs much deeper than that, of course, as you'll see on the next slide. So this data set is from one local authority, where we have a mental health nurse embedded within the housing team. The colleague has been in post delivering this support for about a year. During this time, they've supported 50 individuals. The colleague has successfully worked with 9 people who were sleeping rough to come in off the streets. They've also prevented a further 9 people needing a hospital admission who were already in community-based accommodation, usually a temporary emergency or interim solution. The 2 supported hospital admissions referred to are facilitated admissions. So these were planned in response to an individual's deteriorating mental health presentation. These planned admissions are often a lot shorter than emergency admissions or involuntary detentions under the Mental Health Act. There have been 14 referrals made to our social care authority. These are for people who are in the community with unmet need. All 14 are now either in receipt of social care support or in the process of being assessed when the data was collected. If that support isn't in place, there becomes a significant risk to the sustainability of somebody's chances of maintaining a home or moving on from a temporary setting. 2 people were identified as needing a more supported setting than the temporary provision could provide. These individuals were referred to and accepted by specialist supported accommodation providers, meaning they're now receiving the care and support they need appropriate to their needs. And the final one I'll pull out is the number of accommodation breakdowns that have been avoided. 10. That's 10 people who haven't been evicted from their home due to mental health deterioration or ill health. Instead, they were supported to access the help or treatment they needed, and as a result were able to maintain their tenancy. Secondly, I'd like to bring your attention to some fantastic work we're doing to reduce the social stresses in our service users' lives. Usually there's something going on in somebody's existence which leads to them coming into hospital. There might be debt, issues at work or with family, relationship breakdown, problems with landlords or legal disputes. Colleagues in our hospitals are not equipped to deal with that. Traditionally, their only real option is to signpost somebody to the likes of Citizens Advice post-discharge. The evidence tells us that people don't go. Perhaps they lack the confidence or don't know what to ask for, don't like the formality of the setting, have legitimate concerns about being stigmatised against, or perhaps are embarrassed or don't want to tell their story again. Ultimately, whatever the reason, they go home and hope that the problem will go away. Of course, it doesn't. It gets bigger and more out of control until their mental health is impacted and they end up back in hospital. To address this, we've been piloting a new service with Citizens Advice in one of our hospitals. A Citizens Advice caseworker works directly with our service users for 3 days a week. The outcomes are truly phenomenal. In the 9 months of the pilot so far, Citizens Advice have worked with 51 people who have each had an average of 5 distinct advice needs. They've helped to address a total of 292 distinct advice need areas during this time, an incredible impact. And this is just one person working in one mental health hospital, don't forget. The main advice areas, as you might expect, are around finances and housing, but they've also supported people with issues around hate crime, safeguarding, legal issues, transport, all sorts, the whole range of Citizens Advice services. The most impressive outcome for me, perhaps, is that their advice has resulted in a total of £68,000 of financial benefit for these people. Around £52,000 of that is maximising income, getting people onto appropriate benefits or the right level of benefit, meaning they are more financially stable and secure and better placed to lead a settled life once discharged. The remainder is debt or expenditure reduction. We've also recently started working more closely with our colleagues in the Department of Work and Pensions, and now have job centre colleagues delivering drop-in sessions for our service users. Their work focuses on getting people ready for or into work. They're also able to prevent unnecessary and inappropriate benefits sanctions, which make it more difficult for people to return home. These interventions result in us being able to discharge people more quickly and in a more sustainable way. The trusted relationships service users have built with Citizens Advice or job centre colleagues create a feeling of hopefulness, that life can be different and better after this admission. These support offers continue in the community, providing consistency and continuity for people as they transition out of hospital. People who are more settled are much less likely to end up in a situation where they need to repeatedly access some form of temporary accommodation or emergency healthcare. What the implementation of these opportunities demonstrates is a fantastic desire within the system to do things differently, to work in innovative ways that better support our most underserved populations, and to support people to lead their best lives. To achieve that, though, we need to share information within a governance framework and build trust between partners. We need to allow individuals and organisations to be more agile in responding to local issues they're seeing. One size doesn't necessarily fit all. We need to continue to remove the stigma that's often attached to mental health, homelessness, or people living in temporary accommodation. And we need to ask ourselves the question, are we serious about ending homelessness? How are we continuing to use the COVID legacy and programs like Everyone In that enabled us to work in a much more collaborative way than ever before? So everything I've talked about just now has a direct correlation back to homelessness and temporary accommodation use and the sustainability and success of that provision. For me, we see too many people placed into bed and breakfast many miles away from their support networks or their mental health teams. These temporary placements are only ever going to result in negative outcomes for the individual, the local authority, the landlord, and the NHS. So why do we continue to do it when there are much more proactive, positive steps we can take? And thank you. Any questions? Happy to open it up. Let me stop sharing so I can see you all. There we go.
Thank you very much, John. It's great to hear about it. It's music to my ears. Moving away from a purely medical model, even as a doctor, I think it's really important. Can I ask, I mean, everyone, if you raise your hands or write questions in the chat, as I say, but can I ask how your job came about?
I made it up ultimately. So I used to work for a national care and support and housing provider. I'd been trying to work with the trust for some time. Was leaving my previous post through a voluntary program, and happened to bump into the chief operating officer at the time, the chief operating officer of the trust at the time. And he said, look, I'd like to. He was new into post. I said, I've been trying to engage with the trust around out of area placements, around delayed discharges, things like that, and the solutions that the organisation I was working for had. Been trying to work with the trust for 18 months, 2 years, not really getting anywhere. Lots of appetite, lots of interest, but nobody really wanting to do much about it. I said, I'm leaving. Professionally, I'd like to see something move on before I go. Personally, I think I could probably just come and do it for you. And kind of that's how it started, really. So it started as a temporary role, as a fixed term contract, just to kind of test it out, see what the scope of it might be, see what the impact of it was. And that was 3 years ago, and
All right.
I'm still here, and the role has expanded and is now permanent. And there's other trusts that are kind of taking this model, using my job description as a bit of a blueprint to kind of do something similar themselves.
Fantastic. That was going to be my next question, whether it's been welcomed, but it sounds like it has been. I think Phil Timms has got his hand up. Phil?
Hi there. Can you hear me okay?
Yep,
Yeah, hi Phil.
We can hear you, but not see you.
Hi there. Hi.
No, I can see you. Yeah.
I can see you. I just thinking that a lot of the work you described as the sort of things I used to see CPNs in our team doing, and I'm wondering if this sort of less, I won't use the word medical, but biological activity has been squeezed out of CPN's job descriptions over the last few years. I don't know whether I'm out of touch, so this is a genuine question to everybody here who might be more in touch with what's happening.
I think Phil, other colleagues by all means come in, but I think where we started or how we got to these joint roles where we've got mental health and housing practitioners was really out of that sort of situation, really, this sense of frustration. So we started with one local authority who have, they're a stockholding authority, so they own their own homes. They've got a very, very strong support offer to their tenants that are in their temporary accommodation, and therefore they're seeing their tenants very regularly. They see them multiple times a week. So they see when people are starting to deteriorate, when people are becoming unwell, and therefore they would ring up the duty community team and say, we've been to see John Pritchard 3 times this week and he's really not well. You need to go and see him. And the community teams, where they were really busy, would say, oh, okay, but we're really busy. We should be able to go and see him next Wednesday. Well, next Wednesday's not good enough. We need to see somebody now. Well, I can't go now. And and this real frustration was building between the teams. So, collectively between the organisations, we kind of absolutely understood that we needed to do something different to address that, and that's where these joint roles came from. This sense of coming together, this sense of trying to manage that unscheduled workload that was hitting the community teams. And the beauty of that particular model is we haven't added any resource to the area. We're just
Sure.
using the resource in a different way. So, you know, we've taken somebody from the community mental health team, and they're now in this joint role voluntarily. We haven't, you know, there's actually a real interest from colleagues in these roles.
No, it makes perfect sense to me. Yeah.
You know, so we haven't added any resource. You know, we've taken a colleague and we're using that resource in a different way by picking up that crisis calls and the unscheduled workload at source. Means that the rest of the community mental health team can actually go about their day-to-day business, delivering a much higher level of care and support to their scheduled caseload, because they're not getting pulled all around their geographical calls.
Great. Okay, thanks for that.
Thank you. There was a question from Jeff in the chat. Does the NHS have any plans to use your service model in other areas of the country? I guess you've answered that it's been used as a blueprint.
Yeah, so there's myself covering Southern Health. There's an Associate Director of Housing in Sussex Partnership, a guy called Chris Harris. We're the only two currently. I know that there are plans for at least one other up in Rotherham and Doncaster.
Fantastic. And Barney has his hand up. But Barney, I should have said, can people introduce themselves when they ask a question? Because I guess a lot of people know who people are and some people maybe don't. But Barney.
Hi, yes, I'm Barney. I'm Director of Enabling Assessment Service London. I'm a mental health social worker who's worked in homelessness for a long time. It sounds really interesting, and the statistics are really sort of positive. I suppose I've just sort of, I suppose sometimes, and I think your answer to Phil addressed some of this, I do sort of feel it's really important for a mental health professional involved in working with someone to get to grips with what's going on with their social situation. And if, you know, a local authority says someone's intentionally homeless or is questioning the reasons why they should be seen as a local connection, it's really important that the key work, the care coordinator and the psychiatrist sort of have enough of a sort of buy-in to be able to mobilize their knowledge of the person and their professional authority in making that case. And I suppose it's just sort of, is there a danger ever in your model, do you think, that sort of the people who aren't the housing specialist are even less likely to get to grips in sort of dealing with some of those things which are relevant to their particular individual? And is there a sort of safeguard against that?
Yeah, I guess that risk is kind of inherent, isn't it? What we are doing, however, to sort of mitigate some of that is reducing that silo working and bringing teams together. So the mental health practitioners that we have, the nurses that we have that are in these joint roles are located in the housing teams. They have, you know, if they are, so we have a variety of models as these things develop over time. So we've got some of the colleagues that are employed by the local authority on a fixed term contract. Those colleagues are clearly employees of the local authority and therefore have access as any other employee would. They also then have an honorary contract with Southern Health, so they access still our case management systems and our you know, all the patient records and things like that. There are other models where we're seconding colleagues in, so you know, they remain a colleague, they remain an employee of Southern Health, and then they have an honorary contract with the local authority to get access to their buildings and systems and IT and you know, and all the rest of it. Regardless of the model, we as Southern Health continue to undertake the clinical supervision of those colleagues. We continue to do all of their education and training and learning and development. So we're doing everything that we need to do so that they can retain their registration. So that there is this sort of this matrix management, if you like, of the individual, which does prevent some of that breakdown and some of that silo working reappearing, I suppose. So local authorities are managing the day-to-day management.
Anyone in? He was there early.
The local authority are managing the day-to-day workload of that individual, and then we're managing the sort of the career element and the registration and the clinical aspects of their role. But yeah, there is a great sense of team between the roles. The colleagues are bringing in the primary care resources, they're bringing in the mental health teams as necessary. If we've got somebody in hospital that's been discharged to one of those areas who we know has a very complex housing history or a very complex housing situation, we can bring that mental health colleague in very early as part of the discharge planning, and then they can advocate for them within the local authority, within the housing element. Our social care element across Hampshire is provided by Hampshire County Council. We're a 2-tier authority area, so that the housing and the social care elements are provided by different organisations. But there are, as I say, there's 14 referrals gone through in that one particular area. 14 referrals were made through to social care, and as you see, there was kind of great engagement and great outcomes as a result of those.
And I suppose but you're confident that the individual workers who have an allocated role because of their mental health role remain engaged and knowledgeable and able to contribute. It's not that they don't sort of almost forget. I mean, I suppose there could be a danger of them getting even more focused on a very specific intervention which is health related and not have that understanding. I suppose that was my caution.
Yeah, no, absolutely no.
Two hands just got up. Alex Bax was first. Alex.
Thanks, Jenny. John, really interesting. And that's, I think it's fascinating, the roles, existence, and anything we can think about doing to, I can't remember the quote, to encourage the others to try and spread this around other mental health trusts to say, look, what can be done. But I was just, and on that point, I was really interested in some of your data. How much, so for example, that income maximisation figure with the CAB work seems really interesting and great. How do you, but I can see that might be quite a lot of work for someone. So how are you managing the kind of generation of information about your impact? Is that have you got other people working on that? Or do the staff do it themselves? Can you say a bit about it?
Yeah, CA. So in terms of the data, so the joint roles, so the mental health and housing practitioners, the majority of those roles are currently being funded by DLUC Rough Sleeper Initiative grants. Okay, so the local authorities, who are in effect, the grant holders, are obviously needing to report back to DLUC on what they're doing with that grant. So they're managing that data stream in terms of their caseload and their impact. And obviously we're input into that from a mental health perspective. I have got engagement. We're about to start a formal research project with my research and development colleagues around the impact of that role, looking at the social impact of the roles on the individuals that they're working with, but then also the commercial aspect for us as a trust and the local authority to kind of get some really robust data and evidence around that. So from a day-to-day, month-to-month caseload type data perspective, then that's managed by the local authority. For CAB, again, they're effectively managing that whole element. So they're pulling the data out of their case management system. That 68k is cumulative, so we can expect to see that go up quite rapidly the more people that they work with, because obviously all the time people are remaining on those benefits, then that's additional income that we've secured for them in effect. But yeah, it's a truly phenomenal number for those figure for those 51 people that they've worked with.
Thank you.
Okay, and last question probably is Phil again. Phil.
Hi, John. Again. Would it be fair to compare this to the kind of division of labour you get in surgery, where you get elective surgery and emergency surgery as separate streams in separate buildings, which has huge gains in efficiency for elective surgery and emergency surgery, because your guys are kind of picking up the urgent calls, if you like, and the CMHT is doing the day-to-day stuff.
Yeah, absolutely. I suppose so. Yeah, I suppose
okay.
so. So yeah, it's yeah, the joint roles in particular, where we've got the mental health practitioners, you know, a lot of their role is focused around admission avoidance. You know, what can they do to
Yeah.
support people much earlier in their illness, in that particular cycle of illness?
Again.
You know, and keep them well at home, keep them supported, get the right people kind of wrapped around them.
Yeah, great. No, that makes a lot of sense. I just find myself worried that, you know, generic CPNs are losing this sense of all-round care that I've seen in the past. And certainly even when I was working with SLAM, there was a lot of pressure on nurses to become depot, you know, injection giving machines rather than dealing with, you know, housing benefits and all the other stuff. And I have to say, when we had housing officers and housing workers and benefits workers embedded in our team, they never lasted more than a year, but they were always fantastic kind of bonuses. You know, they proved themselves to be essential actually, and then were taken away. So
and
kind of, it doesn't matter how you do it.
That's absolutely, and that's the beauty of this. You know, for me, this is about us bringing our constituent strengths together. This isn't about the trust trying to do everything. You know, this is about us bringing the expert advice and guidance services from Citizens Advice into our service users who would struggle to access them otherwise. Likewise with DWP, you know, again, we can suggest that somebody goes to the job centre and when they're discharged, because, you know, to sort their benefits out or whatever it might be, but they're really intimidating places to go, you know, security guards on the door, and people don't want to go, they don't like going there, you know.
Understand that.
Yeah, and you know, and this won't be by any means, this won't be unique to Southern Health, but a lot of people that come into our hospitals don't necessarily tell us, or perhaps they're not in a space to be able to tell us that they're on benefits and they should be at the job centre tomorrow for a regular appointment, and they don't go, and we can't tell anybody because they've not told us that they should be going, and their work coach can't get hold of them because they've got to bring their phone with them, or you know, whatever it might be, and they end up being sanctioned, and you know, then they have no income. And if by you know, one of the most impactful things we've seen of citizens of the job centre coming in is, you know, they can say, oh, hello John, I didn't know you were in hospital, and they can put a little note on John's file to say John's in hospital. So then when the work coach looks at John's file to say, why hasn't John turned up today? Oh, he's in hospital. Okay. You know, and then therefore John doesn't get sanctioned, and therefore his housing continues to be paid for, and he's still in receipt of an income, and therefore he's not incurring debt, and therefore when he's ready for discharge, he's got somewhere to go back to, and it's much easier to discharge him there.
Right. Thanks.
Well, that's a nice note to finish on, because that sounds terrific, doesn't it? People not getting sanctioned, I think we could all agree on. Thank you, John. Thank you for coming and talking about this. It is very interesting to hear about, and I hope it can be copied elsewhere. I think you need to leave, is that right?
I do, I'm afraid. Yeah, I need to dash off, but yeah, okay. If anybody has any other questions later on, then yeah, feel free to filter them through either Sophie or Jonathan, and they'll make their way to me.
Fantastic. Thanks again.
Brilliant. All right, thanks everybody. I'll leave you to it. Have a good day. Bye.
Okay, and now we're going to have something completely different. I believe we're moving on to Alasdair Churchard from Oxford, who's going to talk to us about autism and homelessness, which also sounds very interesting. So over to you, Alasdair.
Thanks very much, Jenny. And yeah, thanks very much, Sophie, for arranging for me to come along today. I'm really happy to be speaking with you all about this. Let me just share my slides so I can get going. Can you see the full screen slides now? Yeah,
yes.
I'm seeing nods.
Yeah.
Brilliant. Yeah. Okay, great. So yeah, my name's Alasdair Churchard. I'm a clinical psychologist. I work partly in a clinical service in the NHS, not actually in homelessness. I work in older adult services. But I also work most of the time at the University of Oxford Clinical Psychology training course. And the reason I'm here to speak with you today is that I've done a fair bit of research on autism and homelessness, and now looking to develop this as an area of research in general, but also looking at psychological research as a whole in homelessness. And I'll speak a bit about the work that we've been doing at Oxford in collaboration with other people like Nick Maguire down at Southampton, and other people in Anna Tickle up in Nottingham, to develop what we think could be helpful research. And yeah, I'm very much here today to get your thoughts about what we're doing, to kind of get a sense from you as a group about what might be helpful next steps for psychology to take in the homelessness field. But the bulk of today, I will be talking about autism and homelessness. And I should say thanks to Victoria Acevedo, who I've done a lot of work with on this area. Many of you will know her. She's a rough sleeping commissioning manager at Westminster City Council. And some of her slides I've taken from previous talks we've done together. So I think I've shared most of this already, so I'll move on quickly. But yeah, the bulk of the talk will be on autism and homelessness, and then a little bit at the end about general psychological research in homelessness and what options and opportunities there might be there. So to begin with, about just laying the groundwork of what is autism, because there's a lot in the media about this, but often there can be quite a few myths out there about this, which are important to dispel, really. So autism is made up of 3 characteristics: differences in social understanding and interaction, so understanding what might be on other people's minds, intentions, motivations, and so on, and then differences in interaction. I'll kind of flesh that out a little bit later when I talk about this in the actual homelessness situation. Inflexibility and sensory differences, so that might be rigidity, difficulty coping with change, difficulty with bright lights, loud noises, if we're talking about sensory differences, those kind of things. And it's a lifelong condition. So people are born with autism, they don't catch it. It's nothing to do with things like, for instance, the MMR jab or things like that. And it can't be cured. And it's important to say that it shouldn't be seen as a disorder. The preference in much of the autism community is to speak about it as a condition, not a disorder, which is important, I think, when we come on to thinking about strengths that might attach to it and how to support autistic people who are experiencing homelessness. Many people might see autism and homelessness as related to gender, but it's historically been seen as a male condition. But actually, the suggestion is that male-female ratio is much closer, about 3 men to every woman in more recent research. And also, most autistic people do not have an intellectual disability. That's another myth that's out there. So just some basic things there about what makes up autism. And reasons why it might be connected to homelessness. So it's well established that autistic people, unfortunately, have much worse outcomes than the general population. So statistics here about much lower numbers in some form of paid employment, much higher rates of mental health problems, much higher rates of social isolation. And these are all obvious risk factors for homelessness, right? So there's good reason to think that autism might be a risk factor for homelessness. Also, I put on here, don't forget strengths, because it's very easy, isn't it, to just jump into kind of pathologizing kind of way of talking about things. And actually, it's really important to think about ways that we can work with the strengths that autistic people bring when in supporting them to exit homelessness. So the way that we looked into this is we did a bit of research when I was doing my clinical training at UCL, which showed that of a sample of long-term people who are long-term rough sleepers, 12% of that population showed strong signs of autism. That's in comparison to a rate of about 1.1% in the general population. So it's important to caveat this. We did not diagnose people with autism. We can't be sure that they were autistic, and it was only looking at one population. It's not looking at not looking across the homeless population, but it did start to provide more support for more evidence that actually autistic people might be at high risk of homelessness. And what this might look like is, if we come back to those areas I described, what makes up autism, one part is social differences. So social understanding is understanding what might be on other people's minds. So there's an example here of someone who doesn't initiate social interaction. You kind of walk up to them, wouldn't do the usual social niceties of saying hello or so on, not giving tangential responses. Another person where body language was a difference. They didn't make eye contact. They had blank facial expression and had to be told when interactions were finished. if someone is not having difficulties with social interaction, we come to the end of a meeting, we might just stand up to indicate, oh, it's over, and people would pick up on that. For this client, they wouldn't. And I think it's quite important to think about what this might mean for someone who's living with homelessness, who's got this style of social interaction. It's probably going to make them more vulnerable and more at risk, isn't it? And it's probably also going to make it harder to provide support for them. So that's one way I think in which autism and homelessness could be linked. The other major area of autism that we picked up in our research was about this area of restricted and repetitive behaviors and interests. It's got examples here of someone who had their room organized in a certain way and followed a very precise routine, someone who had very fixated interests, so had a large collection of broken electronics, and sensory differences, someone who, when they were they really picked up on noise, so if a fire alarm went off, it was very difficult for them. And these might seem just like details of someone's presentation, but if you kind of see this in the round mixed in with social differences, what we've picked up on, we think, is that this really affects someone's experience of homelessness and potentially makes them much more at risk and more vulnerable. And I want to kind of give an example of this. Could someone let me know if you can hear the audio when I turn this video on? It's showing an autistic child's experience of having of sensory differences, of picking up on things like noise, sound, and noise, light, and so on differently to most people. And while this is it's an autistic boy, exactly the same kind of sensory differences would be present for an autistic adult. You might kind of think how this kind of thing might affect someone living with homelessness. Yeah, so can someone tell me if you can't hear it when this starts playing?
Six, 7, 8, 9. Take my hand. No, Alex. No, it's fine, isn't it? It's fine. I'm not naughty. I'm autistic. And I just get too much information.
So I hope that kind of gives you a bit of a sense of, that's just one experience of autism. You know, every autistic person is different, but I hope that gives one sense of how the sensory world for someone with autism might be different. And actually, we can imagine in a busy day centre, you know, a hostel where the fire alarm's being tested, there's lots of loud noises, how it might be a very difficult environment for an autistic person, and might go some way to explaining to some individuals why providing support for them is more challenging, or why they're reacting in ways which are hard to understand if you don't know about the sensory differences. And that will play out in different ways across the different kind of aspects of autism, as I already described earlier. So one other thing I want to highlight is just about autism and trauma. We know that trauma is kind of such a key consideration in providing support to people living with homelessness. And there's evidence from work with the autistic population in general that they're at higher risk from others in general. So that probably also translates to experience on the street. Not understanding, for instance, that someone who maybe appears to have good intentions might actually wish them harm, that type of thing. Might want to take advantage of them in one way or another. And there is some evidence that autistic people are at increased risk of developing PTSD and the types of trauma they experience less likely to be recognised. So trauma related to sensory differences, for instance, not being picked up on. And one hypothesis I have is that these combine to make it more difficult for autistic people living with homelessness to make use of the support offered. I can go more into that if people have questions, but yeah, a kind of variety of things here, factors to consider in terms of the experience of autistic people living on the streets or living in homeless situations. And I won't go through this, but there's a fantastic paper came out recently looking more at the lived experience of autistic people experiencing homelessness. I can share these slides afterwards, and this kind of fleshes out a bit more of the actual the type of experiences people are having. So based on this research that we've done, I developed this toolkit. I led on it. I was working with Victoria Acevetum and then these other organisations listed here. And if this is an area of interest to you, you think it might be relevant for your services, for people you're working with, I can share the toolkit. There's some other materials around it which kind of go a bit deeper into it, but it's a guide for services really, how to recognise autism and how to adapt support for autistic people experiencing homelessness. And we're currently updating it to make it to bring in some other features, working with autistic women experiencing homelessness, for instance. And just to kind of give a brief summary, what we argue in this is you can continue to follow the best principles associated with psychologically informed environments. So working with strengths, focusing on the client's priorities, and using relationship building, but you do need to adapt approaches to meet the specific needs which are associated with autism. And here's just some examples. So one thing that I've heard Victoria talk about a number of times is relationships that key workers develop, maybe moving from long key work sessions where you're really giving the person a chance to kind of sit down, spend a long time, get comfortable. Actually, that might make an autistic person feel distinctly uncomfortable. It's not in every case, but it might be for many individuals. So then turning more to short and regular meetings, that type of thing. Being consistent, being hugely important. Being aware of differences in sensory sensitivity, being aware, for instance, are you meeting in a room where there's a very bright light, like strip lighting, when an individual's got sensitivity to lights, that kind of thing. So yeah, I won't go too deep into this, but just to kind of give you a bit of a flavour of the type of things that we're thinking about in the toolkit. But what I want to kind of finish up with was, Jenny, do we have how much longer do we have?
Well, we've got till 11. I think there'll be questions. I've got lots of questions.
Yeah, I'll wrap up in a couple of minutes then. So I just want to kind of broaden out from Autism just a little bit to say that I'm very interested in further developing psychological research into homelessness, and obviously there's many other psychologists like Nick Maguire, Steve Weatherhead up in Liverpool, lots of the team working in SLAM and so on who want to do the same thing. And the reason I'm interested is because the paper that I referenced earlier, where we got that 12% figure of percentage of that population who might be autistic, that was the first paper published on autism and homelessness at all. There were no previous academic papers in the field. And I'm pretty certain that there will be other areas of work which psychologists can have done work in which are the same, where there might be other areas of homelessness where psychologists could do some really useful work which hasn't been done before. And there are parallel examples. So things like I mentioned Steve Weatherhead, his work up in Liverpool on brain injury and homelessness, for instance. And I've kind of got questions for you as a group about what other areas of homelessness should there be more psychological research in. There's lots of questions here about how we adapt our research design, kind of stepping outside of our comfort zone, I think, as psychologists, to working in a field where I think probably part of the problem historically has been that it's felt too difficult for psychologists to do work in homelessness. And actually, that's something I'd really want to address. And also accessing resources, how we get the funding and so on, making homelessness part of the curriculum so that this research actually happens. So I'd be very interested about your thoughts as a group about what we could do about that. And what we have done is I organised a homelessness research seminar earlier this year, where we focused on a number of areas like autism. We also looked at hoarding and addictions, among others. And we're planning to follow up on this with an online workshop later this year to develop some more concrete research ideas. developing a consensus statement based on that research seminar about what next steps might be based on our experience of conducting psychological research. And I've been in discussion with Joe Prestige from Homeless Link about possibly some kind of guidance document in the area or even an academic paper, because I think there are some kind of underlying issues which need to be addressed to make psychological research happen, really. And also just, doing this networking. I want to make as many links as possible to hear about others' thoughts and to hear, how we can do research which is not ivory tower stuff which actually makes a difference for people living with homelessness. So so thank you for your time. I've got the references there for some of the things I talked about. I can share these slides along with the toolkit. But any questions, any thoughts you had, I'd love to hear them. Thank you for your time.
Thank you, Alasdair. That was, as I thought it would be, really interesting. I'm sure people have got questions, and so either, as I said, put those in the chat or raise your hand. And if anyone has ideas about further research in psychology. Alasdair, are you connected with the Psychology and Homelessness group? There's another group. Yeah,
the one run by Emma Williamson kind of has set it up, I think, didn't she?
I'm not sure who runs it. Yes, I think she does.
Yeah.
Okay, that's good. And Sophie is saying that we can continue with the research discussion as part of the hot topic discussion, which we're going to have after this. So that's good. I just wanted to ask a question about diagnosis, Alasdair, if I may jump in. Because I hear what you're saying about it not being an entirely negative diagnosis to have, and there are strengths as well, but it does seem like it would be useful for people to have a diagnosis, because I think that can lead to options in housing. We have a problem that the waiting list for assessments in the trust is very long, and often so long that people have moved on before they even get a diagnosis, which isn't very helpful. And so our psychologist and I trained in ADOS so that we could do it ourselves, which has been, we haven't actually managed to start doing it yet because there's some sort of extremely expensive toolkit that we need to buy before we're allowed to do the assessments, which is problematic. And it's quite difficult to do. Like, we did 4 days of training, and it was still something that I struggled with, to be honest. I wondered if you had any advice about how to help people to get diagnoses, or whether there's any screening tools that we could use, and what you used when you got that 12% of people, which is really high, isn't it, experiencing homelessness. Was that a thorough assessment, or is there screening that we could do that might suffice, or any thoughts you have?
I can share, so I can share some materials if you're interested, Jenny. If you drop me a line after this and let me know what you're particularly interested in, I can do that. The short answer is that diagnosis can be hugely helpful, but we don't think it should be the be all and end all. We talk about this a bit in the toolkit. There's a number of factors here. One is that it's such an extended process that we just don't think it's going to be possible for everyone who we think it might be relevant to. You're asking people to join for a very long assessment individually, but you're also typically using you're looking for details about how they were as children. Obviously someone who's living with homelessness, they may well have lost touch with family. You may just not be able to speak to the necessary people to get a sense of whether the kind of autistic symptoms developed early enough, because there is the huge confound of trauma, right? It's not clear. So I don't want to go too much into this, but I would just say it can be hugely important, but we don't think it's the be all and end all. We encourage people to adapt support, even if there isn't a diagnosis in place, in a thoughtful way, and in a kind of really considered way. But we don't think that diagnosis is something that we don't think everyone should get a diagnosis before support is adapted.
Thank you. Sarah Ketley is just saying in the chat that it can be helpful, and they recommend what they use in their clinic. And we have similar problems with ADHD, actually, that no one ever gets diagnosed. So we try to do it ourselves, but then no one gets any service. So I guess that would be something for further research, maybe. I guess it's going on already. Phil has his hand up.
Yeah, hi. What do you think about the Royal College of Psychiatrists autism screening stroke diagnostic tool?
I'm not. Do you know the exact name of the tool, Phil?
No, Dan, it's just on the RC Psych website, and every time anybody mentions autism, somebody puts their hand up and says, the Royal College has a screening tool. Now, I've never used it, and I suspect that any sensible diagnostic tool will actually help you to understand a bit more what's going on with somebody with autistic traits or whatever. But it's something that is underused, and I've no experience of using it myself. Hence my question to you.
I'm not familiar with that one. I mean, so we did the research actually in like 2016 or something using this tool.
Right.
So I think my view is that I think you want people to feel like they're able to recognize autism based on those, and if we have some suggestions in the toolkit for things to look out for, those social differences, those repetitive behaviors, and to kind of not feel like you need to make yourself a huge expert in autism. And the types of adaptations we suggested to support are they shouldn't do any harm. You know, that's something we focused on. So
my personal interest is in this. One of my major misdiagnoses when I was practicing with START was a man with autism who I misdiagnosed as having a psychosis. He turned out very well. He went into hospital for a couple of weeks, came out, and seemed much more comfortable. He had a diagnosis of autism, but I think we wouldn't have got to that if autism wasn't recognised as an issue as much as it is these days. And if I'd had a tool like the RC Psych one, hopefully I might have actually done a better assessment. So
I'll check that out. And I do have the tool that we use in our research. I think could be one option in terms of screening.
Right. Lovely. Thanks.
See, there's I see there's a few questions. I'll go for the last one. Jeff, you've asked about experts by experience. We're working with a number of people with experts by experience now. As we develop the work further, we didn't at the time, I'm afraid. I mean, it was kind of an oversight, but I think also possibly showing how little we knew about how we were just, I guess, doing an initial exploration of the area. So we're involving experts by experience now in this work.
Thank you. And Denver had made a comment about the right to choose. Do you want to say anything about that, Denver?
So I used the right to choose a couple of years ago for myself. I had been misdiagnosed with various mental health issues, and then finally realised that I am ADHD. And obviously with ADHD and autism, they are both very undiagnosed, especially for women. I'm really interested to get more research and look further into the prevalence of both autism and ADHD in sex workers, especially. It seems in my circles and my experiences, it's a really, really common thing. And the waiting lists is something that seems to have a big impact on sex workers not even attempting to get an assessment. But being able to provide resources and guidance on how to use right to choose has been really helpful for people in my networks. And obviously this is just from personal experience, these are not service users, but there has been having that sort of self-advocacy skills and allowing people to feel like they also are empowered to do this for themselves as well, I think has been really really positive.
Could you say what the right to choose is, Denver?
Oh, sorry. No, I was. So the right to choose is essentially you have the right to choose where you're referred to, as long as there it doesn't have to be your local service. It can be anywhere that.
Message saying we were down here. Haven't seen Hilary at all.
Hillary's on annual leave.
Oh, the whole week. Or
I think someone's not on mute, who maybe should be on mute. Go on, Deborah. So you can choose to be referred you can choose to go anywhere, can you, for?
Yeah, as long as services are commissioned by NHS anywhere else in the UK. So the two main providers for ADHD assessments are Psychiatry UK and ADHD 360. And Psychiatry UK have also started doing autism assessments as well. The waiting list for them is about 6 months to a year. There is quite a lengthy wait after diagnosis for titration as well, which is also difficult for people. But even just having confirmation that difficulties are not down to a personal failing or not due to something like BPD, which is a really stigmatizing diagnosis, seems to me to have a really big impact in the way that people engage with services and improve their outcomes. And when we look at the advantages of getting a diagnosis, even though with autism there isn't, any medication or anything, sort of like an easy fix, it does give people access to other forms of benefits, things like access to work grants, which you can get government grants to fund things like noise cancelling headphones and other support equipment in the workplace. I think whenever we talk about accessibility in services and making things accessible, we should always be considering neurodivergence as well as physical disabilities. Sorry, I've lost my train of thought. It's something I'm deeply passionate about, so I would bang on Freighters if given the opportunity.
That's great. Well, thank you very much for sharing your experience. That's really useful. Sarah, you've had your hand up patiently for ages. Over to you.
Oh yes, I guess first off, just to say, as the work you did in Westminster has been really excellent. Kind of like setting the scene for really creating, I think, incredible changes in the delivery of services and recognition of the importance of autistic spectrum disorder and neurodiversity in homeless populations. So thank you for that. So what we use the AQ10. I could just see someone here uses the RADS 14 screening tool. I guess I was using the AQ10 in a clinic, mostly based on, I know that it's a bit clunky and there's lots of debate about whether there's any use at all, but I guess NICE recommends it. And so it's a very simple, easy tool to complete, and it does give a threshold. I mean, obviously some people will, it's not ideal, but it does really allow, because the assessment process is so long if you're going to refer for assessment, that it really allows access into other sorts of services. So you can kind of clearly say, well, they were either just if you get 6 or more, well, we can kind of get the kind of autism support swing into place, including in terms of finances, in terms of support workers. I have to say, in Westminster, there's been it's been commissioned by Victoria. Was a service that Lee Andrews was doing, a kind of SALT intervention. I have to say, the patients or the people that I've worked with who I've referred everyone to that whilst the programme was running. I'm not sure if it's still ongoing. The feedback was incredible. The ability for people to communicate actually what they wanted with a bit of kind of dedicated SALT intervention with maybe 6 sessions. Incredible. I mean, the feedback from the patients is the more incredible thing, kind of really feeling empowered to say something. So, I mean, if people are looking at kind of what other things might you add, because I guess that's the thing, is what do you do? So you might identify this, so then what do you do, and how's it going to make a difference? So I guess it's about so in, SHP and Mongers have got kind of now people with autism champs. You just wonder whether this might be something, particularly in homeless services, and I'd say in other mental health services, that it should be a priority in induction, somewhere in people's early induction, that this notion of neurodiversity, and not just autism, but ADHD and the overlap between these two, and then that, as you say, the confound of trauma, because one would wonder that perhaps those people who might experience neurodiversity might be more likely to experience trauma because they might be more likely to have less supportive relationships and that kind of, so you'd be more likely to have multiple things going on. Anyway, that's just so it's great work, and I do agree with you in terms of the Denver, in terms of the sex working kind of cohort of people that I see as well. I think kind of neurodiversity is probably pretty critical, but again, it kind of overlays with kind of trauma as well, and it's difficult to see what goes first, but I still think you could probably, it makes sense to recognise as an underlying neurodiversity. Anyway, that's what I want to say. Thank you, Alasdair.
Thank you. Well, I mean, I guess for me, it just feels like it's, I hope that this research helps people to kind of, I don't know, have other options to explore with people who maybe they're struggling to know how to adapt support. You know, I don't think, I think in many cases we're not going to get to a stage where we know for certain. In many cases, we don't even know for certain if the person's autistic.
Yeah.
But you know, but there's a kind of, you've got a sense of things that you can try out with them, where rather than it maybe in the past, maybe it might potentially might be, is it psychosis or is it personality disorder? You know, to put it bluntly.
It's completely on the radar, Alasdair. It's completely on the map. You know, like it's part of what we look for, and especially if things don't quite go as you might expect. Is definitely, as Phil said, maybe 20 years ago wasn't really on the map. It's now definitely on the map. So thank you.
Thank you. Just, I think, again, a last question from Tony Jablonski. Has there been much research done into epigenetic links in autism and ADHD, as some late diagnoses seem to indicate an inherited source?
Well, you're pushing me, Tony, in terms of what epigenetic means. I
was wondering.
I think what I can say is that yes, there's definitely a link between autism and ADHD, and there's definitely a genetic component, is I think the kind of consensus. You know, and there's significant overlap between the conditions as well.
Yeah, well, it was a bit, I will be in touch, Alasdair, because I think you're right, Sarah, that it is much more on our radar, but I still don't know that we know exactly what to do when we consider it. I think we consider it a lot, and then I think maybe we get a bit stuck. So your stuff in Westminster sounds fantastic. Maybe we could talk about it outside of here. Thank you, Alasdair. Thank you. Particularly that video was quite traumatic to watch, I found. It was really quite an amazing video. So thank you for sharing that. I think we are going to have a little 5-minute break for comfort before a hot topic discussion by Theo. Is that all right with everyone? I'm going to hand over to Theo for the hot topic discussion.
Cheers, Jenny. Thank you. So first of all, thanks for having me along today. My name's Theo and I work at Pathway as research and data analyst. I've been there for about 1.5 years now. And yeah, today we wanted to have a bit of general discussion around research priorities for mental health within inclusion health more generally. And just to give a little bit of context from our perspective, so at Pathway, we're currently refreshing our research strategy. So part of this involves kind of identifying a prioritized list of research areas. So thinking about evidence gaps that exist and thinking about which gaps have a high potential impact if we're able to fill them. And then for us, there's some associated work around developing our own research networks to get these gaps filled and produce impactful evidence. But also developing a kind of more strategic oversight of inclusion health research nationally as well. So in terms of this group, obviously being the Mental Health Network, we just wanted to have a kind of open floor discussion to get people's thoughts. And I think there are a few kind of key questions that we'd be really interested to just hear people's thoughts about and some debate. I will say I'm also going to share a link to a feedback form as well a little bit later. So if you want to send over some thoughts later on, you can also do that. But it's really good just to hear some kind of group discussion around this. So I think in terms of the kinds of things we'd be interested in hearing about, in terms of mapping research, so hearing about ongoing research. So Alasdair, it was really interesting to hear about the stuff you've been involved with, for example, any kind of future directions for research that people have on their radar or are interested in as well. And then thinking about where some of the main gaps are within this research. So this could be in relation to service design, in relation to clinical care, in relation to policy and influencing work, where people think the main evidence gaps are, and then also which kind of research or new evidence has the potential to be quite impactful in terms of improving things generally. So be as broad or specific as you like in relation to those questions. And I think there's also an interesting question that'd be great to hear people's thoughts about, which is within inclusion health more broadly, thinking about the extent to which mental health is focused on within that broader inclusion health movement from a research perspective. Is it under focused on compared to other elements of health that we might talk about within inclusion health? And I think there's another really interesting thing, if anyone has any thoughts, I'd be interested to hear about, relates to kind of upstream prevention. So we had the Homeless Link health needs audit, which was published recently, and there was some very interesting data in there which suggested that very typically people prior to becoming homeless experience quite poor mental health. They fall into homelessness, and then there's a deterioration of physical health as well. So if anyone has any thoughts about the role mental health research could play in a kind of more preventative upstream context, I'd be really interested to hear thoughts about that as well. But those kind of broad questions, where the gaps are, and what evidence do we think would be impactful, and also any thoughts about kind of future directions for research or ongoing research, would be really interested to hear. So I just kind of want to open the floor up to everyone, just have a bit of open discussion around it. Philip, I can see you've got your hand up if you'd like to come in.
Yes, yet again, sorry. It's about upstream prevention. This would be kind of secondary prevention, really. It's just that when every time we looked at our referrals to the START team, about 2/3 of the people referred to us had previous contact, often substantial previous contact with our trust. So there's a real issue here about mainstream mental health services not managing people adequately so that they then become homeless. And I'm wondering if that could be a focus for secondary prevention. Okay, you get people into your service, but please, can we not make them homeless as well? So there's something, I don't quite know what it is. I don't think anybody can pin it down exactly, but for me, that, obviously I've got an interest as a psychiatrist. I feel that if our services are doing a bad job, we need to look at it. So that's just one idea from me.
That's great, thanks. And yeah, I think we would all agree there's definite lack of early intervention, especially from mental health services, and they probably have quite a lot of potential impact there in terms of engaging with people quite early on in their pathway towards homelessness, let's say. So thanks for that, Phil. Does anyone else have any thoughts they'd like to share about any of the stuff I've mentioned? Jeff.
I'd actually like to have a conversation with you at some point, because I'm going to do some research myself. A while ago, working with Crisis in Newcastle, they were looking at doing some research about GP surgeries, that looking at the websites about how people register when they're homeless, because I know that it's a bone of contention for me, because it's often been a difficult thing. But it never got off the ground, but they were only looking at North Tyneside, and I'm living in South Tyneside, and I'd like to do some research in South Tyneside, because there is quite a high number of people who are homeless here. So basically what I want to do is go through all the websites for every GP surgery, find out what the conditions are, and then call the doctor surgeries and tell them that I'm, lie slightly, I'm working with somebody who's homeless, and I'd like to find out how they go about registering.
Yeah, I would be really, really interested to work with you on that, Jeff. Can I just ask a question, I suppose, in the context of that access to primary care piece, and maybe just linking it to mental health a little bit as well? How do you see kind of improved access to primary care fitting in with improved responses to mental health problems? Do you see that as a fundamental part of that, or do you think that that's more to do with other services and less to do with primary care? I'd just be interested to hear your thoughts about that.
I know somebody who's got ADHD, who's street homeless, who could never get registered with a GP. Every time he went anywhere, they would send him on, oh, you need to go to the GP surgery down the road, they're better. And he'd get down there and they'd be, oh, you need to go to the other, and they would just keep passing him on and passing him on. And I went in with him one day and we got him registered straight away. And his ADHD is now managed. and he's not going backwards and forwards to the hospital, which is what he was doing before. He was in and out and in and out and in and out, and he hasn't been back into mainstream surgery. Hospitals, particularly, not secondary, not primary care, but secondary care. He hasn't been back for a year since he got registered. But if you can't get registered, you can't get the help. So you end up keep going back to the A&E, which is what he was doing over and over and over again.
Yes, Denver, I can see you've got your hand up.
So just on you mentioned about the having ADHD being managed. I did want to flag that because ADHD, the medication is as a class A substance, it means that people who are substance users often do have a lot of difficulties in getting prescribed any stimulant medication. There's a lot of assumption that they're going to abuse it, that they're going to sell it, especially it's something that I've seen happen a lot. And then obviously when people are transient, when you are moving location quite a lot, it means that it's really, really difficult if you lose your medication, if it's stolen or whatever reason you don't have enough. It's really difficult to be able to get it. You can't just ask for a top up from the pharmacy. They're obviously very, very hesitant to just give it out. One thing as well that I've noticed is the lack of knowledge about temporary GP registration, which is if you're living in an area for over 24 hours, up to 3 months, you can register with a GP temporarily. And especially frontline staff don't seem to have any knowledge about that, which I think makes, increases a lot of the difficulties in accessing primary care.
Great, thanks for that. Yeah, I think like as you mentioned, evidencing those kind of barriers to accessing services is a really key part of it, and that's been a thing that a few people have mentioned already in these kind of discussions we're having. So thanks for that. Barney, do you want to come in?
Yeah, I was just, I suppose it's sort of something which might be quite specific to us, but just trying to think about how to evaluate the impact of our service, especially in some bits of our work. It's very much focused on sort of, we're not having direct contact with people who are using services. We're supporting staff teams through sort of reflective practice, case discussion, and training. And I think where we have been involved in some evaluation in the past, it's been like looking at sort of data about unplanned move-ons and sort of referrals from those projects, and it's been that we've done some work with some questionnaires of staff team, but it's thinking about meaningful ways of sort of trying to get the views of people living in services or using homeless services as to whether they perceive a benefit or any change from having housing workers who are getting that increased support. And it's just because it's slightly detached, because I mean, the example I'd give is when we first started working in Westminster, our inputs coincided with a bit of a spice epidemic, which had a major impact on all sorts of things. It was very, a lot of the sort of impact of our work supporting staff teams was very minimal, probably, compared to those external factors. And I suppose it's just we've been thinking and not being able to put enough time into thinking about trying to measure, finding ways of hearing the experience of people using the services where our impact has been supporting the staff team of those services. And any thoughts on that would be really helpful.
Yeah, I mean, I think it'd be great to hear other people's thoughts about that from the group around the best way to show the impact, like you say, and try and really build in that, the perspective of the people who are engaged with the service. And I think it seems like there maybe is a little bit of tension between, really understanding the impact of your service by talking to people and hearing their perspectives on it and how they felt when using the service. And then a bit of a tension potentially with the kinds of evidence you need when you're thinking about funding opportunities and recommissioning and those kinds of things, and how to kind of balance those two. So it'd be great to hear thoughts from the group on that question specifically, if anyone has any, how best to demonstrate the impact of services.
And I suppose just adding, one of the things we've been thinking about is sort of focus groups and sort of working groups and sort of people who've sort of, but again, there are sort of challenges, and I think especially when some of the work is with sort of services which are specifically supporting people through a period of sort of crisis, or social sort of crisis, and it's just sort of what are reasonable expectations to get relatively real-time views from people who've been going through that experience in a way which is meaningful, and there's some tensions there as well. And again, yeah, we haven't sort of got to a solution. We haven't even progressed the conversation as much, but as you say, Theo, any ideas people have got would be really interesting.
And from your point of view, Theo, what is the aim of the research to sort of guide services, or to, I don't know what, but when you talk about research within Pathway, what do you want it to achieve?
I mean, I think all of the research, links back up to our wider strategic goal, which is improving health outcomes for these groups, inclusion health groups. And I think in terms of what the research can achieve, it can achieve things across a lot of different areas. It might be, for example, working on demonstrating the impact of services to enable more services to be created. It might be, more similar to kind of Alasdair's research, which is thinking about the clinical practice and the assessment and diagnosis, or it might be research that can feed into the kind of policy work we're doing as well. So for us, it's anything which could contribute to our kind of broader strategic goals in that sense, whether it's related specifically to services or more broadly. At the moment, we're in the very early stages of this kind of strategy refresh. So very much just collecting different views and perspectives, and in particular, thinking about where those gaps might be, where people perceive the evidence gaps to be, and where new evidence is going to be most impactful. Alasdair, I can see you've got your hand up.
Yeah, I mean, I guess what's coming to mind for me here is, drawing my experience doing research in this area, that it's funny, isn't it, how just an academic paper seems to make quite a big difference. Even though it was well known that autistic people had much worse outcomes in a wide variety of areas. Seemed there was lots of anecdotal evidence about homelessness and autism, but that academic paper did seem it carried more weight. And I guess I do think there's something here about understanding the kind of power that research can have and how it can kind of strengthen cases. And I think there's also something here about how using that research process to really look more closely at the issues being faced, encouraging that kind of like a robust way of looking at the needs that people might have, and so that we can then say, oh yes, it does look like these aspects of autism are related to the experience of homelessness, or these aspects of brain injury, or whatever it might be. And I think an ongoing question for me is how you kind of link up these areas, which are, I think, have been quite like siloed off. I mean, I'm thinking about the field of psychology in general, us as a field not kind of maybe feeling so comfortable doing research in an area which feels a bit more, well, to be frank, kind of chaotic, like homelessness, where it's, there are all these questions about how do you actually do robust research design. And I think it's kind of, I would find it really helpful, I think, to have more of a sense of how to link up across these different areas, so that it feels ultimately actually the research is it's not that complicated. It's just about getting to the stage where you're actually doing it, really.
Yeah, I think that's a really interesting point, and it's to be honest, not something I've been thinking about much, but actually kind of reconfiguring research processes to be as good as they can be for this topic. I think you're right, it's really important and one we should definitely look into. Phil, do you want to come in?
Yeah, just thinking about the issue that has been talked about a lot but never really researched, the sense that specialist homeless services in mental health seem to work differently to mainstream mental health services, and this may be reflected in general health services. And it may be an impossible ask, but I think it would be really interesting to see if this notion is true or not. without resorting to kind of the slightly moralistic, oh, we're much better, we're more understanding, we're more empathic or whatever. I'd be really interested to see if there are issues about the way we organize our teams, about the way we practice that are actually different from, say, your local CMHT. Again, quite a difficult, complicated question, but I think you have to ask, why do our patients stick with us and they don't stick with other services? And hopefully that would feed into prevention eventually. If we could convince, if we are doing something really different, and we can convince the rest of health services to be more like that. Thanks.
Well, I just want to pick up on Sarah. I'm not sure if you're able to go on mic, but just want to pick up on your comments in the chat, something related to policy, something about releasing to streets, both from HMP and even from hospital. Do you want to say a couple of words about that?
Yeah, just can I just quickly respond to, I think just quickly with Phil, got to be a bit careful about what you research, because I think what you might find is, because I work in a CMHT and I work in a specialist homeless service, and the difference is time. It really is, the massive difference is time, and I think that cannot be underestimated in terms of what one's expected to deliver for the populations. And that's a good thing that the inclusion and health services have got more time, but be cautious what you wish for, because that might be the thing that gets cut. So just going back to policy, I would say our experience at Great Chapel Street is that we're seeing a lot more people being discharged straight from HMP, straight to the street, even from hospitals as well, straight to the street. You know, we've got someone, you know, in the last month, shall we say, who, you know, they're on a depot and they're on complicated physical health medicines, discharged to the street. They have got a probation officer. They have an established previous kind of couple of chronic long-term illnesses. And it's kind of like, how is that okay? I mean, how is that okay? Does the system allow that to happen? Because actually there's risk for the individual, there's likely risk for other people as well. And it seems like a very poor, a missed opportunity for intervention. So so when coming back to what Alasdair was saying, that in a way the academic paper kind of told people, put it in language that policymakers recognise, so that you could then put it into nice guidance, you could then put it into policy practice. And so maybe the lesson is that we should be looking to kind of do some evidence and some papers on what we think are the top 3 things that we kind of know, and then we you know, try and find a paper to evidence that then might then be able to change practice. So in terms of policy stuff, it's, you know, it's not that complicated, I don't think, to do a kind of, you know, where do people go, or how many people, you know, if from the outreach things ended up coming straight from prison, or, you know, from like probation within London, how many people did they not place who were coming out of prison, and how many people ended up in a certain area, and of those, how many people had, you know, physical or mental health difficulties, for example. That's just what I was thinking.
Yeah, I couldn't agree more. So just to interject, there's ridiculous the number of people who are going straight to the streets when they're known to the inreach team and on a depot. I'm very angry about it. We've got meetings going on within the trust, but it would be brilliant if there could be something bigger than that.
Yeah, thanks. That's really interesting. I think as well, there's also something around, something we've been thinking about a little bit, is the kind of presence of a mental health condition, let's say, that the interaction that has with the kinds of housing offers that are accessible to you and that are made to you in the first place, obviously relating to discharges to the street as well. So I think that's a really key area. Thanks. Graham, do you want to come in? I think you're on mute.
Thanks, Theo. Yeah. So I've come in a bit late. I had post marathon munchies, so I might have missed your initial chat about this. So I think I'm trying to answer what I've heard so far. So in our area, CMHT staff are pretty much down 42% on what they should be at the moment. So when we're talking about preventative work, they're struggling enough at the moment to do those that are referred in. And that's the reality on the shop floor, I think, from what I hear at the moment. So, but for me, as from the Homeless Health Service in Dorset, I think the assertive outreach kind of model and the engagement model, for me, there's probably a lot of research out there that's you'll all highlight me to. However, for me, I think that's a key element for us to look at, and we just need to convince somebody to pay for it. That's my thoughts.
Cheers. Thank you, Graham. Jenny, do you want to come in?
Yeah, I thought I'd put my hand up for once. Just so I thought about the other thing that is making me really cross at the moment, and it's people with no recourse to public funds because of Brexit. A bit like people with no recourse to public funds generally, but particularly people who have been impacted by Brexit and now have mental health problems that were entirely caused by that decision and now are homeless because of that decision. And it would be, you know, when the kind of weighing up of the whole Brexit scenario happens, it would be good to have some research saying this put all this burden on mental health services and housing services and everybody else. And yeah, it makes me very cross.
Yeah, I think that's a really key one as well. We are currently interested in, looking into a little bit more detail about the experiences of people with no recourse to public funds. But I think that the Brexit specific cohort is a really interesting one to look at. And I think, highlighting that as a really key problem and coming from that political decision would be really interesting as well. There's Jenny again?
No, sorry, I'm just failing to organise my hands.
So does anyone else have any thoughts they'd like to share on this? Alex, do you want to come in?
Yeah, thanks. Sorry to miss the beginning, Theo, but sounds like a really interesting discussion. Just to share another perspective from Pathway, and again, a question is, so part of the thinking behind this work is maybe there is some power collectively in us to not only working out what the research priorities are for us collectively, but also publishing them more widely, so that because we're not going to fill all the gaps, but if we can agree what we think the top ones are, then it also puts us in a strong position to say to other people, whoever they are, we need some help here, guys, or to academia, to NIHR, etc. So part of the thinking here is how do we produce something which has that impact, as well as helping us to decide where we focus our always limited resources, but also whether we can use it to itself to have some impact in terms of other parts of the system.
Yeah, thanks, Alex. Sarah, do you want to come in?
Yeah, hi. Yeah, I mean, I think that's right, Alex. Having some sort of sense of what is the priorities and kind of publishing widely to see what we can gather. But I suppose the one factor you might want to take into account. So, and I have to say, sorry about this, but I'm kind of involved in this one day a week, so I'm slightly not quite in the full flow of money and policy. But I think there's some important things of like where is the money likely to be coming from? Which part of the system is the money likely to be coming from over the next, say, 2 to 3 years? Because any sort of research is probably going to take a year to complete, a year to do, but then you may have enough evidence to kind of like jump into whether it's, you know, stuff with the ICSs, whether it's stuff to do with kind of, I don't know, safeguarding, like where the money's coming from. Like, is it coming from local, obviously with devolvement and stuff, there's all sorts of stuff going on. The public health budgets have now been, you know, smashed into the local authority. So it's, I guess, working out where the likely money sources are going to be that might help drive where some of the evidence might be gathered to then support applications for service change.
No, I think that's completely right, and I think part of our motivation for engaging with this work is to, you know, have that overview of different funding opportunities and then be prepared for them when they do come up. And as Alex said, be prepared for them, but from a kind of cohesive perspective within Inclusion Health, where we can, you know, notify these opportunities and say, you know, we have a large network of people who have this as their priority, and we can kind of very easily and more quickly go for these opportunities. I think that's really important. So thanks for that. So if there's nobody else who wants to share any thoughts, like I said as well, I'm going to send around a link to a Google form where you can just leave your thoughts about kind of evidence gaps, research priorities, and any other comments as well. Would be really grateful for any further feedback that people have. I've taken quite a lot of notes from that discussion. It's been really helpful for thinking about it. So thanks to everyone for your thoughts.
Thank you, Theo. It's just there's conversation going on in the chat, so I think probably everyone like me is thinking more and more things that they're getting cross about and what they'd like to research into. I'm still fuming about no recourse to public fund. So we are coming to the end, so this is all timed very well. Thank you for that, Theo, as well. Brilliant. Okay, thank you. There's no more hands up, and it is 11:57, so that's good. Thank you, and particularly Sophie, thank you so much for organising such an excellent and thought-provoking meeting, and thank you everybody for coming and having your thoughts provoked. It's been really good, as it always is. I think the next meeting is in July, beginning of July, before the summer holidays start.
July before the summer holidays.
Yeah, fantastic. So are you looking for ideas for that meeting?
Yes, if anyone has anything that they would like to present, please do get in touch with me. I will just put my email, even though you probably have received emails from me, but I'll just put it in the chat as well. But if you know of someone that I should get in touch with, let me know as well. Thank you.
Great. Okay, thanks again, everybody, and see you soon. Bye.
Thanks, everyone. Bye-bye.
Bye, everyone.
Thank you. Goodbye.